Hello, everybody. Thank you very much for joining this joint webinar between ISTAP and WCET. And we're here really to celebrate Norma N. Gill's birthday today. So we're absolutely delighted to be sharing all this information about skin tears and skin frailty with you. I'm Professor Karen Uzi, and I'm the current president of ISTAP. And today's webinar is entitled Skin Health and Skin Tears, Doing the Right Thing, a shared vision for evidence and informed clinical practice. The programme, as you can see, is in front of you. You've got a full packed programme, and we're going to be going from the history of WCET and ISTAP through to questions and answers. So please do take the chance to ask your questions during the webinar, and we'll attempt to answer them all at the end. But I just wanted to tell you a little bit about ISTAP, and I know that Kim is going to do a full history for you shortly. So in January 2016, we became an official interest group of nurses specialised in wound, ostomy and continence in Canada. And as you've realised, it will be our 10-year anniversary next year. So please do look out for all the things that we'll be doing. We've got a range of international partners that you can see on the screen. And we'd also like to thank our corporate supporters of Monica and Essity for helping us. We have a successful World Without Skin Tears Day every year. It was held this year in April, and as you can see, it was fun-packed and everybody really enjoyed it. But we had 1,671 total registrants, of which there was just over 800 on the actual live webinar. And you can see that we had at least one registrant from 66 different countries. And we're absolutely delighted about that because it's shown that ISTAP has really got a global reach. This year as well, we decided to use Wordly, and Wordly helps to translate all the English into any other language. And as you can see here, we had various different languages used throughout Wordly, from English, Turkish, Spanish, Danish, Cantonese, Persian, etc. And this really helped the day because it translates simultaneously as the person is listening and speaking. So it makes it much more beneficial for our global colleagues whose English isn't the first language. We're also involved in a range of different collaborative research projects that we'll be sharing over the next 12 months. One of them is a joint project with the European Wound Management Association, and we call that Living with Skin Frailty and Skin Tears. Through this, what we want to do is enhance digital storytelling so that we're able to share stories of people actually living with a skin tear. So this will be a series of digital and audio resources. It's for educational purposes, and once completed, it will be on the ISTAP website for people to be able to go to, have a look and use themselves for education or research or just updating your own knowledge. We've also developed a range of skin models. So these are 3D printed models, and you can see examples of them here in front of you. We've developed this in collaboration with the University of Huddersfield, and we're hoping this is really going to help with education of people who work with skin tears. And as you can see, we've got a range of different skin tones, and we're also able to teach students with these models to reapproximate the flap as well. So please do contact us if you want to know more about these. And of course, we're very excited that in May we launched the new ISTAP best practice recommendations for the prevention management of skin tears and aged skin. The original document from 2018 was still being used widely, but there's been a lot of new evidence and research since that time. So we've completely re-evaluated the document, added in new evidence, new research, and this is in collaboration with NSWOC and the WOCN. So we're absolutely delighted that our collaborations and partnerships are showing that we can truly work together in a holistic fashion. This is available to download free of charge from the Wounds International website. So please, when you get a chance, do go and have a look at that. And for the eagle-eyed amongst you, you may have noticed that ISTAP now has a trademark. So we're absolutely delighted with what's been going on. But Kimberly will talk you through the whole the history of ISTAP up until the present day very shortly. So all that's left for me to do is thank you very much for joining us on this really exciting event, which is joint with the WCET. Enjoy the webinar and please do use the question and answer boxes for any questions you may have. We'll be able to look at those throughout the sessions and we'll reply to them at the end. So please don't be shy. Do ask your questions. I look forward to hearing from you all. And once again, enjoy the webinar.
Hi, my name is Kimberly LeBlanc, and it's my pleasure to be here with you today to really outline the history of the International Skin Tear Advisory Panel. I would like to start by doing a land acknowledgement that in Canada, where I have the privilege of living, working, and playing, we live, learn, and work on the traditional Indigenous territories. We pay our respects to the First Nations, Métis, and Inuit ancestors, and affirm our commitment to respectful relationships with one another in this land. And I'm coming to you today from the unceded territory of the Algonquin Anishinaabe Nations. So what I'm going to do this morning is just give you a brief overview of the evolution of the International Skin Tear Advisory Panel, known as ISTAP. So we've come a very long way. We know we still have a long way to go, but we've really come a long way. If we look back, the skin tear literature evolution, Sharon Baranowski really led the charge. Prior to 2008, there was very limited publications. And you can see here that the majority of the publications between 1990 and 2008 were authored by Sharon Baranowski. And the reason she was so interested in skin tears was because this was her mother who developed multiple skin tears. And this is what really spurred Sharon to want to study these wounds. During the World Union of Wound Healing Society's 2008 conference in Toronto, Canada, with the mission to advance the life of persons with wounds worldwide, skin tears made it to the international agenda for the first time. And Sharon and myself got to be co-presenters on a session, and this is where we met for the first time and realized we both had a passion for skin tears. We began to wonder how could we get skin tears on the radar of clinicians and to be recognized as the complex wounds that they are. Flash forward to 2010 in Florida at the Clinical Symposium on Skin and Wound Care. Sharon Baranowski, Don Christensen, Tariq Alam, and Mary Regan and myself sat down to discuss how could we, just some clinicians, get together to discuss skin tears and raise the agenda. And this was really the birth of ISTAP. It started with Sharon and I wondering how can we, two nurses, fund research and educational development? Can we learn from others? We knew that Carolyn Carville and her team in Australia had developed the STAR skin tear classification system. So we really thought, how can we build on that journey? We needed sponsors, and this is where we were lucky that Hollister did agree to come on as our initial corporate sponsor. ISTAP now has multiple different corporate sponsors, of which we are eternally grateful for. In 2010, we developed a survey looking at the knowledge, attitude, and practices of nurses globally looking at skin tears. Bouncing from that survey, it was the foundation for what became the State of the Science consensus statement for the prevention, prediction, assessment, and treatment of skin tears. And this is what really brought skin tears first to the global stage and really started to raise awareness. So we had our founding members, which were Sharon and myself, who was also included Tariq Alam, Karen Campbell, Carolyn Carville, Don Christensen, Karen Edwards, Mary Glockner, Samantha Holloway, Diane Langmo, Alicia Madore, Mary Ann Salmon, Ann Williams, and Mary Reagan. From there came the International Skin Tear Advisory Panel's ISTAP Skin Tear Classification System. This is where we defined and classified skin tears, and we went on to do validation. And I'm so proud that since this time, it's been translated into multiple different languages, and it has been validated numerous times. So we've been working diligently for over 14 years to raise the awareness of skin tears. We know that we have a unique organizational model with strong and diverse regional representations, which contribute to our success. Since 2011, we've been involved in more than 34 peer-reviewed publications. We've published a wide range of scientific evidence, for example, in the form of guidelines, consensus papers, and research articles. In 2016, we were thrilled to be recognized by the World Union of Wound Healing Societies as the most progressive society. We've been involved with and developed studies of our own classification system, the result of which has been comprehensively tested, as I said, worldwide. The scientific literature demonstrated by the over 1,200 articles on the topic published between 2012 and 2022, including 57 clinical trials. Today, the International Skin Tear Advisory Panel is a growing organization focused on the prediction, assessment, prevention, and treatment of skin tears, and therefore the skin health of the most vulnerable people in our global society. And you can see here our current ISTAP board members. Leading the charge is our president, Karen Usi. And the only founding member still on the board is the immediate past president, Samantha Holloway. But you can see we're now very diverse in terms of a geographical organization. So for ISTAP, the sky is the limit. I am so excited to see where ISTAP is going to go next. I hope you will all become members and continue to follow along with us on this journey. Thank you.
Welcome to our Norma N. Gill birthday celebrations. As many of you will know, Norma Gill was the founder of the World Council of Enterostomal Therapists, the WCET. I've been asked to talk a little bit about its history. We are a world of expert professional nurses caring for patients within the tri-specialty of ostomy, wound and continence needs. We are a registered charity, and in a nutshell, our mission is to lead the global advancement within the specialty, and our vision is to make sure that specialised nurses are available around the globe to care for these patients. So our tri-specialty, ostomy, wound and continence, represented by these new logos. We are encapsulated by education, and we do consider that the shared knowledge here is really about the skin. I will introduce our executive board. Fiona Bolton is from Australia, Dr. Angela Baccara from Brazil, Dr. Katie Capitello from the USA. Our current president is Laurent Chabot from Switzerland, and I'm the current president-elect. I've been fortunate enough to lived and worked in many countries, and so I was born in the United Kingdom. I've worked for 35 years in Saudi Arabia, and during this time I've been very, very proud to call Ireland, Thailand and more recently Portugal my home. So we do have an international flavour. As do our committee members. We are all volunteers across the panels, committees and the executive board. The 5 executive board members are the charity trustees. We have 47 education committee members currently and 22 Norma N. Gill committee members, which provide a global representation. We have a Congress advisory panel, a past president advisory panel, a constitution advisory panel, and currently we have 62 international delegates representing the 70 countries that we have members in. These wonderful people provide a connection to our country members, and also they provide us with information on what's going on in their country, so we're very grateful for them. So now let's talk about the birthday girl, Norma. Norma was born in 1920, and by 1948 she was diagnosed with ulcerative colitis. At some point she met Dr. Rupert Turnbull, who was a colorectal surgeon at the Cleveland Clinic, and by 1952, during her third pregnancy with Sally Gill Thompson, who was Norma's third child and also an enterostomal therapist, her condition flared. She developed all the comorbidities that come with inflammatory bowel disease, and she was very sick. In 1954, she needed ileostomy surgery with removal of her rectum, which is quite a pioneering surgery at the time. During her long recovery, which I think took about 3 months, she had lots of conversations with Dr. Turnbull, where they both agreed that there was a lack of ongoing support, education and counselling for patients with ostomates. By 1958, she had worked towards this, and she became officially the patient advocate technician educator at the Cleveland Clinic, Ohio. In 1961, she started the very first US education program. It was aimed at teaching laypersons, ostomates and their carers to care for other ostomates, but in actual fact registered nurses and doctors attended the program and were very grateful to Norma. By 1968, she'd founded the first national association in the USA, and this was a massive achievement for someone who was a patient. She had no medical or healthcare background, and so she was an amazing person. Norma then started to look globally, and she discovered that there were already education programs in the UK, France, Australia, Canada, South Africa and Sweden. Patients were involved, but there was also a lot of nurses involved. In 1976, she met she chaired a meeting at the International Ostomy Association conference in the UK where they discussed how they could help more globally, share resources and share education. And by 1978 in Italy, in Milan, they founded the WCET, and there were 15 country representatives in attendance. Norma became the first president. So we are proud to say that we are an association that was founded by patients towards the improved patient care. By 1980, Norma and the gang decided that they really felt that nurses were the best placed to offer education and care for patients with ostomy wound and continence needs. And so Prilly Stevens became the first RN WCET president. Up until 1985, they spent a lot of time and energy spreading the word globally, connecting with people, trying to find out who those special people were in different countries, and developing a network of contacts. They travelled to other countries doing congresses, but also providing education, and they developed education criteria. In 1980, the first journal was available free to members, and by 1982, the first sustaining journal partner was Convatec. Today, we have 7 sustaining journal partners. Thank you to Calmoseptin, Coloplast, Convatec, Danzak, Diriol, Hollister, and Welland. And today, we actually translate the journal into 4 languages other than English, and this is professionally done at great cost. So we thank Coloplast China for the Chinese translation. We thank Calmoseptin for the Portuguese and Spanish. We are still looking for support financially for the French. We are an open access journal, and this year we celebrate the 45th anniversary of the journal. We need to do a call out to Greg Paul, Jenny Prentice, Elizabeth Alo, Gordon McDade, who represent Cambridge Media in relation to the WCET publications. By 1999, they were looking at sharing knowledge across the globe and the resources, and they wanted a more formal way of doing this, and they came up with the idea of twinning, so putting together countries that already had established programs with developing countries that were looking to develop programs, and there's a list there of successful twinning programs. We'd also like to applaud the many individual RNs and doctors who travelled to the States and other countries to receive training and bring that training back to their own countries, and we'd also like to thank the individual RNs that have travelled to other countries to provide education. Thank you to all for working towards Norma's mission and vision. We applaud all of these country pioneers, and I can't call them all out one by one because we don't have time, but all of these people offered significant contribution to the development of services within their own country. Today we have 69 recognised programmes. We do understand that there are many other programmes that have not asked for recognition. We would love you to donate towards our scholarships. We have Congress scholarships, education scholarships, travel scholarships, membership scholarships, and scholarships that provide educational resources. So please go online at the WCETN.org and donate to one of these charitable funds. We do have a biannual congress that has been going on since 1978, and we do try to go to a different continent each time. And in 2026, we would love to see you in Vancouver, Canada, where we are joining the Nurses Specialised in Wound Ostomy Continence Care Canada for a joint congress. The Parade of Nations is always very exciting, and again we celebrate our international delegates or their country representatives. They dress in their national costume, they bring their flags, we call them up on stage, and they do a parade around the exhibition, and we celebrate their great achievements in all these different countries. We want to call out our past presidents who have all of them achieved great things during their tenure as president. I don't have time to discuss all of them individually, but we thank them. We do have a past president advisory panel that was started last year. I'm sure you recognise all of these people. They all have met Norma or known Norma in a different way, and so Norma is never very far from our discussion and our mind when we meet with them. We honour our life members. They all brought something to the WCET, but all gave greatly to their countries and had achievements within their own countries. As Laurent always says, we are better together. And so we do try to connect with other like-minded organisations. We have many memorandums of understanding. We're also affiliated with the International Council of Nursing to have a more global reach. These are some of our publications, and some of the guidelines are translated into other languages. I mentioned the journal. We also have the bulletin produced 3 times a year, which is a more newsy view of from our members in different countries. Our international ostomy guideline is being revised as we speak, and we're hoping that will be available in 2026. We thank Dr. Emily Eisler because she has been the methodologist during this revision. If you want to know more about the WCET history and Norma, you can download these resources online. I want to remind you that we will be in Vancouver, Canada with NSWARC from the 24th to the 28th of April. Abstract submission is open, so please go ahead and submit your abstracts. And thank you for helping us celebrate Norma's birthday.
It's my pleasure to get to talk to you about skin injury prevention. So here are my disclosures. So really what I want to look at this morning is to define the concepts related to skin vulnerability, describe shared risk factors for skin conditions such as skin tears, moisture-associated skin damage, pressure injuries, and skin changes at end life, and to discuss ways to maintain or promote skin integrity. So a lot of what I'm going to be talking about is going to stem from the holistic strategies to promote and maintain skin integrity. And this came from some best practice recommendations from an expert working group. So this concept of skin integrity is widely used in many different areas, and healthcare contexts as a formal definition is lacking. So often what we'll see are many different terms being used, such as skin frailty, fragility, integrity, tissue resilience, skin failure, and dermatoporosis. And so agreement has yet to be reached in the literature regarding a definition for the individual terms or concepts when we are talking about skin vulnerability. So skin frailty is what we're really suggesting is the umbrella term for at-risk vulnerable skin. And a proactive approach needs to be taken to protect the frail skin and prevent damage. So we need to make sure that individuals, families, and carers' education and support is required so that whenever possible, they're able to help maintain their own skin integrity. It's important not to conflate skin frailty with overall frailty. So while consensus of the exact definition of frailty has not been reached, it can neither be classified as a result of the aging process nor as a disease. It has been described as a health condition of decreased functional reserves, leading to a vulnerable state with the inherent risks of multitude of adverse outcomes. But this is not the same thing as skin vulnerability. Frailty is an umbrella term that encompasses interacting physical, physiological, social, environmental, and economic factors. And frailty can be seen as a dynamic or changeable state depending on the interaction of these factors. So when we're looking at patient groups at risk for skin frailty, we can see that we have older adults, individuals living with mobility issues, children or neonates, individuals with spina bifida or cerebral palsy, bariatric patients, oncology patients, and chronic illnesses or other issues. And so when we look at the potential problems, we can really see how skin tears are really found in almost every population. Skin changes that make the skin vulnerable to injury can be classified as extrinsic, such as environmental damage, so regular soap use, prolonged sun exposure, smoking, or pressure, or intrinsic, such as the effects of aging and the effects of skin conditions such as psoriasis or atopic eczema or any other underlying illness. And we need to further look at these risk factors that can be classified as modifiable or unmodifiable. And I'm really interested in the modifiable factors. So what can we as healthcare clinicians do to modify someone who is at risk for who's vulnerable to injury to ensure that they don't go on to develop injury? So if we're looking at a framework for skin frailty, if an individual's skin has enhanced vulnerability, they're at increased risk of damage to the skin. So I think that's pretty easy for us to follow. So we look at those risks being skin tears, pressure injuries, moisture-associated skin damage, and skin tears at end of life. And we know that there's growing evidence that show that these distinct skin conditions can be linked, and that we can do a bundled approach to prevention and treatment. So we really need to look at that interactive approach, tackling the synergy of the main risk factors for these conditions. And Dr. Campbell and her team did a great job of looking at these different clinical phenotypes and looking at a new approach at reducing risk factors overall. So the aim is to move away from a siloed way of thinking and to consider all these conditions in the broader context of skin frailty. So skin tears are the most common wound found among the elderly, although they are not the only group who will have that risk skin. Skin tears are defined as traumatic wounds which can be caused by mechanical forces, including removal of adhesives, and that severity may vary by depth. We classify basing on the severity of the flap. In individuals with skin frailty, we know that less force is required to cause a traumatic injury, meaning the risk of skin tears is increased. When we look at pressure injuries or pressure ulcers, how you define them, it depends on where you live in the world. But a pressure ulcer is defined as a localized damage to the skin and or underlying tissue as a result of pressure or pressure in combination with shear. Pressure usually occurs over a bony prominence, but may also be related to medical device or other objects. So we need to look at how pressure injuries are developed. Is it the result of immobilization, such as being bedbound, or is it in combination because of individuals' comorbidities and general poor health? So we need to look at prolonged chronic disease and overall frailty. And we know that the majority of pressure ulcers are avoidable, meaning prevention is the main priority. When we look at moisture-associated skin damage, this is a complex and increasingly commonly recognized condition. It's a type of irritant contact dermatitis, and common irritants can include urine, stool, intestinal liquids from stomas, and wound exudate. There are 5 types of MASD: incontinence-associated dermatitis, intriginous dermatitis, peri-wound skin damage, peristomal skin damage, and trench foot. The development and severity of MASD depends on a number of factors and is commonly found in individuals who may be affected by intrinsic factors such as excessive perspiration, increased dermal metabolism, abnormal skin pH, history of atopy, deep body folds, dermal atrophy, and inadequate sebum production, or intrinsic factors such as incontinence, perspiration, chemical or biological irritants, and other environmental factors. When we look at skin changes at life end, these are found in individuals at the end of life, and they're experiencing skin changes and have specific care requirements. These skin changes are related to increased overall skin frailty and are also known as skin failure. Skin failure is an event in which the skin and underlying tissue die to the hypoperfusion that occurs concurrent with severe dysfunction or failure of other organ systems. I encourage people to look at the scale document that was put out in 2010 by Dr. Sibold and his colleagues. And the scale document states that the physiological changes of dying can cause unavoidable skin or soft tissue damages despite care interventions that meet or exceed the standards of care. So if we're going to focus on promoting skin health and skin injury prevention, we need to look at a comprehensive skin assessment. We need to know the skin history. We need to know the patient medical history. So we don't just ask our patients, do you have a history of, say, diabetes or high blood pressure? We need to ask our patients, do you have a history of skin issues such as pressure injuries, skin tears, moisture-associated skin damage, or other skin issues? Does the patient have intrinsic factors for vulnerable skin, such as old age, diabetes, or thin skin? Is the skin intact? Does the patient have wound-related risk factors, such as eczema, infection, high exudate levels, edema, or pitting? Is there a skin condition present? Is there anything unusual, such as a rash or dryness? How does the skin feel to the patient? Assess the patient's knowledge of his or her own skin condition. So knowing how the individual's skin history will really play a lot in terms of how we prevent things moving forward. Do they have any known allergies? Have they been exposed to other extrinsic factors such as sun exposure, tobacco, alcohol? If they've had previous wounds, what worked in the past? Do they have any odor? We really want to make sure that we're gently assessing all aspects of the skin. Now, the International Skin Tear Advisory Panel did come up with a risk reduction program that can be used to really look at preventing skin frailty across the spectrum. So first of all, we need to know the patient's history. We need to really look at that full skin. We need to consider medications. We want to prevent trauma. We want to implement an individual care plan using skin-friendly cleansers. We need to look at moisturizing skin twice a day. Dr. Carville and her colleagues did a wonderful study where they looked at moisturizing skin twice a day in vulnerable patients and found that they were able to reduce the hospitalized incidence by almost 50% of the skin tear development. We want to look at encouraging active involvement in exercises and mobility. We really want to look at maximizing self-care and making sure that we have a safe environment. We need to educate the patients, caregivers, and healthcare professionals on skin frailty and the risks and damages. So if we come back to Dr. Campbell's work, we can see that we have patient factors, system factors, or structural factors, situational factors, and then how we have in this Venn diagram the overlapping contributing factors. When that's added to exacerbating elements such as moisture-associated skin damage, pressure, shear, friction, these are considered exacerbating elements. And when combined with potential risk factors, this is where we end up with potential skin injury. So when we want to look at implementation into practice, we need to have a person-centered care that prioritizes the needs and preferences of the individual, their families, and carers. We want a comprehensive holistic assessment. We want a formulation of a plan that looks at the prevention of skin tears, moisture-associated skin damage, and pressure-related skin damage into that plan. We want implementation and an ongoing evaluation. We should also look at having an ongoing pain management assessment and evaluation. The principle of care at risk skin should be evidence-based, consistent, fundamental dimensions of care that are continual. We want to maximize activities of daily living. We want to promote the facilitation of mobility, including repositioning and use of appropriate equipment, promotion and maintenance of continence and appropriate continence care, promotion and facilitation of optimal nutrition and hydration, and full individualized skincare regime. So these principles of skin care should be taken an evidence-based, person-centered approach. And the assessment should trigger monitoring and an individualized care plan for those who are at risk. Promoting skin health and preventing skin injury in vulnerable individuals should be a priority in all aspects of care. So I think the most important takeaway here is we need to think about the skin in everything that we do, so that we're always thinking, are we reducing shear and friction? Are we reducing pressure? Are we managing moisture? If we do this with every patient encounter, we're going to promote skin integrity and prevent the skin injury.
Thank you, Karen and Laurent, for the privilege to present as a member of ISTAP and WCET my thoughts on the science underpinning skin tears, which are multifactorial in nature. My declarations are listed here. I will briefly discuss the definition and morphology of skin tears, associated risk factors, data on skin tears, and opportunities for future research. Our skin is our largest body organ. It defines our origins of ethnicity and reflects who we are throughout our lifespan. Commonly, however, we pay the least attention to our skin from a health perspective. This includes the lack of acknowledgement globally that skin tears are a preventable injury, which is reflected in the fact that the World Health Organization have yet to recognize skin tears with a specific ICD-10 code, despite an estimated incidence of over 1.5 million skin tears per annum. Debate continues around defining the structural and clinical characteristics of skin tears. Following a review of 13 articles, Rayner et al. Proposed a revised definition based on reference to pathology, cause, effect, and site of injury and affected population. Subsequently, skin tears were defined as trauma-induced partial or full-thickness wounds, which primarily occur on the extremities of older persons with age-related changes to the skin's structural and mechanical support properties, and are commonly associated with elastosis and/or ecchymosis. ISTAP revised an earlier definition of skin tears to include the effect of mechanical forces, removal of adhesives, and patient handling to be more reflective of skin tear causation. If a skin injury extends beyond the cutis or subcutaneous layer, it is no longer considered a skin tear and should be described in accordance with the mechanism of injury or etiology of the wound. In 2022, ISTAP, through Delphi processes with 17 international experts, added an additional clause defining skin flaps and skin tears to clearly differentiate between skin flaps used in surgical skin grafting. ISTAP has a validated skin tear classification tool, which is available on the ISTAP website, which assists in identifying the severity of a skin tear once the skin tear has been realigned. And Samantha will discuss this further with you. The clinical characteristics of skin tears present differently due to the magnitude of blunt force trauma, cause of the trauma, anatomical location of the injury, structural integrity of the skin, and the individual's health status, inclusive of medications such as anticoagulants, chemotherapy agents, and steroids. Skin tears may have linear or jagged edges or no skin flap, be small or extensive in size, may be superficial or deep, and may occur in conjunction with a small or deep dissecting hematoma. Characteristics of skin tears in skin of color may present differently than that in Caucasian skin or other skin tones, as erythema, ecchymosis, and skin pigmentation may vary depending on melanocyte concentration and activity. Assessment should include tactile and visual processes and discussion with the person or carer, if possible, on the cause of injury. There are multiple risk factors for skin tears across the age spectrum, which are intrinsic or extrinsic in nature. For instance, neonates are more highly susceptible to MASI or medical adhesive-related skin injury, especially from repetitive skin stripping which damages the epidermis and dermis. Risk factors may also be modifiable or non-modifiable. Modifiable means susceptibility to skin tears can be mitigated by either managing cutaneous skin conditions, assessing for falls risk, or changing our approach to clinical care. With the exception of photoaging, risk factors listed here are largely intrinsic, non-modifiable factors due to aging and disease processes, inclusive of cognitive impairment. When multiple non-modifiable factors are present, the prevention and management of skin tears is challenging. There are differences in the morphology of skin tears across the age spectrum that we need to be aware of. In summary, the skin of neonates, preterm neonates especially, are immature. Key factors are decreased adhesion between the epidermis and dermis that decreases the skin stability and increases the likelihood of the detachment of the dermal-epidermal junction from shear, friction, and pressure. In addition, as the skin microbiome is not in balance, being more alkaline, There is the potential for bacterial infection from injuries such as MRSA-related skin tears and for delayed wound healing. Aging of mature skin and resultant physiological or structural changes in skin appearance and skin turgor are pertinent to the individual. Effects of intrinsic and exposure to extrinsic risk factors that result in, for example, dry skin from reduced natural moisturizing factor. Morphological changes in the epidermis, dermis, and subcutaneous tissue, such as flattening of the epidermal junction or rate ridges, decreasing and weaker vascularity, decreases in collagen fibers and viscoelasticity, and increased transepidermal water loss of the skin, results in skin fragility, skin dryness, and increased risk of skin tears. Dermatoporosis encapsulates under one term factors associated with aging skin, leading to progressive cutaneous skin insufficiency and fragility that makes aging skin more susceptible to trauma. Skin fragility is associated with decreased levels of keratinocytes CD44 and hyaluronan, which assist with normal hydration and viscoelasticity of the skin. 5 stages of skin changes and/or impaired skin integrity are defined to assist with assessment, preventative or therapeutic interventions associated with dermatoporosis. Stages 1 to 3A are most associated with bruising and skin tears. Due to a lack of epidemiological studies, the prevalence and incidence of dermatoporosis is uncertain. However, one French study estimated 32% of elderly people aged over 60 were affected. Bruises can occur in the skin and subcutaneous tissues following violence, intentional or unintentional blunt force trauma at any time within the lifespan of an individual. Bruising may exhibit varying degrees of tissue trauma depending on the age and health status of the individual and location of the injury site. Research has highlighted common factors suggesting strong pathophysiological links between bruising and skin tears. Lewin et al. In 2016 determined that ecchymosis, senile purpura, hematoma, and evidence of previous skin tears and oedema as the factors associated with skin tear development. Sequelae of dermatoporosis inclusive of ecchymosis in addition to thinning of the dermis with weakening of collagen bundles and elastosis, the aging process, photoaging of the skin, and their combined impact on wound healing processes are recorded as either independent or codependent risk factors for skin tears. Dermatoporosis with skin changes only and/or impaired skin integrity have linkages with bruising and skin tear development. Residual tissue damage from bleeding into the surrounding tissue and associated localized edema increases skin fragility and susceptibility to skin tears. These factors are enhanced in the presence of hematomas, particularly lower limb hematomas, where severity is often underestimated, as bleeding may occur at different rates due to the force and location of the injury, medications, and underlying comorbid conditions. Re-injury of previously bruised skin also potentiates skin tears. Anatomically, and because of aging, the extracellular matrix of the dermis loses its strength and resilience, and the rate ridges at the dermal-epidermal junction flatten, which further contributes to skin fragility as a shared factor for bruising and skin tears. Morphological differences between a young and older person's skin primarily lies within the structural integrity of the epidermis, dermis, and subcutaneous tissue. Comprehensive, worldwide, and accurate data on the prevalence and incidence of skin tears is lacking. Interpretation of data is also compounded by multiple factors, including different data collection methods, definitions, inter-rater reliability between assessors, classifying skin tears, and reporting bias. The new updated ISTAP data collection tool should mitigate many of these issues. Similarly, there is a dearth of research on skin tears in people with skin of colour. Racial or ethnic variations frequently reported as ceramide content, structure of the stratum corneum, filaggrin mutations, and transepidermal water loss with drier skin. Other considerations for future research are the cost of skin tears, factors relating to quality of life, and further work on skin morphology and skin tears to achieve international consensus on skin tear definitions. And, as indicated earlier, further prevalence and incident data is required to substantiate the need for a specific ICD-11 code for skin tears. There are references attached to this presentation for further reading. Thank you for your attention, and please visit the WCET and ISTAP websites for further information.
Hello and welcome to the session on assessment of skin tears. My name is Samantha Holloway and I'm the immediate past president of the International Skin Tear Advisory Panel. I'm also a reader at Cardiff University School of Medicine and the programme director for the Masters in Wound Healing and Tissue Repair. So I'm delighted to be able to speak to you about the assessment of skin tears in this session. So first of all, I'd like to start with the updated definition of a skin tear, which, as you can see, is a skin tear is a traumatic wound caused by mechanical forces, including removal of adhesives and patient handling, the depth of which may vary, but it does not extend through the subcutaneous layer. And this is really important when we're thinking about assessment of skin tears in terms of classification, but also in terms of differential diagnosis as well. So building on this notion of differential diagnosis to support accurate assessment, why is this important? Well, skin tears are often confused with pressure ulcers or injuries, moisture lesions, irritant contact dermatitis, tension injury, pretibial lacerations, hematomas, but we do include medical adhesive related skin injuries as skin tears. So you see here a selection of wounds that are often confused with skin tears. So how do we differentiate skin tears from other injuries? Well, there are lots of reasons why you might be doing that, but I think two really important factors are that think about the mechanism of injury. So a skin tear is often caused by blunt trauma, falls, equipment, being helped with activities of daily living, for example, and location of injury. So skin tears are usually on the limbs, so the upper arms, the hands, and also the lower limbs, particularly the shin. So both the definition of a skin tear and differential diagnosis is important then in terms of assessment. So here I present to you the ISTAP toolkit, which is a collection of resources that is a useful guide to assessment of skin tears. So you have the risk assessment pathway, the skin tear decision algorithm, the classification system, the pathway to assessment and treatment, and also a prevalence study data collection sheet. So I'll be talking to you specifically about the algorithm, the classification system, and also the pathway to assessment. So if we look at the algorithm in a little bit more detail, you can see that it includes some important steps of assessment, which is the first step. But in order to do that, you need to control any bleeding. You also need to cleanse the skin tear. You need to reapproximate or reposition the wound edges of the skin tear flap, and then you classify. So let's just have a look at that in a little bit more detail. So in terms of assessment, I mentioned controlling bleeding. So here we have an image of a gentleman who stood up from his sofa to walk over to the TV to get the remote control to change the channel. As he stood up, he tripped over the coffee table, fell onto the rug and slipped across the rug, sustaining what is really a nasty skin tear. So the important first aid measures were to control the bleeding. We can do that by elevating the limb, applying light pressure, but being careful not to damage the skin tear flap when you apply pressure. We can use the hemostatic agent dressings such as calcium alginates to stop the bleeding. And then you would expect bleeding to stop within 10 minutes. And if it doesn't, you'd need to seek urgent medical attention. So that's the first step in the assessment of skin tears. Then we need to cleanse the skin tear. So skin tears are acute wounds. They're likely to be contaminated due to the nature of the injury. So for example, blunt force, a fall, or equipment related. So naturally you might use an antiseptic solution to clean the wound because of the dirty and contaminated environment. But if an antiseptic is not available, then use a sufficient amount of normal saline to clean the skin tear. But again, being really careful not to damage any remaining skin tear flap. So for further information on therapeutic and wound and skin cleansing, please see the latest International Wound Infection Institute document published this year. So we've stopped the bleeding, we've cleansed the skin tear, and now we need to reapproximate the wound edge before we can assess it, specifically classify it. So once you have cleaned the wound, you can then use moistened cotton-tipped wound swabs or a moistened glove finger to gently reposition the flap over the wound bed. The choice of method is entirely up to you. People do have different preferences, and it will depend on your local protocols as well. But I would suggest you avoid the use of forceps and tweezers because that may cause more damage to the skin tear flap. So once you've repositioned the flap where it's present, repositioned it over the wound bed, then you need to classify the skin tear using the ISTAP skin tear classification system. So the skin tear classification system was first validated in 2013. So it was a study including 12 internationally recognised key opinion leaders who undertook the initial validation, and then a larger sample size of 327 individuals across the United States, Canada and Europe also undertook a further validation of the skin tear classification system. And this study established that the reliability and validity of the new classification system was strong. So it was therefore suggested that this classification system be used in clinical practice. Subsequently, Hannah van Tiggelen undertook a wider international validation study of the International Skin Tear Advisory Panel classification system. So this was across 44 countries. And the conclusions of this study were again that the ISTAP classification system is a valid and reliable tool to use, and it should be used both in clinical practice and for research. So since that time, and around that time, the classification system has been translated into 14 other languages, as you can see there. So thinking about assessment of skin tears, what are the key message so far would be that you need to reapproximate the skin tear flap and then classify. So if we put into practice the classification system, here we have a skin tear that has been reapproximated. So the skin tear classification system includes type 1, type 2 and type 3, and the descriptions are there. So is this skin tear linear or flap? Can the flap be repositioned to cover the wound bed? Likelihood is not, because we can see some of the wound bed, yet the flap is over most of the wound bed. So partial flap loss describes where the flap cannot be repositioned to cover the wound bed. And type 3 is total flap loss. So what type of skin tear is it? It's a type 2. So once you've done that initial part of the assessment, which again is controlling bleeding, cleansing, reapproximating the skin tear flap, then you need to bring in the pathway to assessment and treatment of skin tears in order to define your goals of treatment. And the goals of treatment and assessment really are based on the principles of wound bed preparation, where T is tissue, or some may use D for debridement as that first step. So it's looking at the skin tear flap, assessing is it viable, does it need to be debrided, being really careful about debridement to ensure that the viable skin flaps are left intact and protecting that fragile skin. And also thinking again about tetanus status due to risk of contamination at time of injury. So for further information and an update, there is a really good document published last year on the best practice for wound debridement, which I would suggest you review. The I of wound bed preparation is establishing whether there's inflammation or infection. So normal inflammation is present in acute wounds, and that usually extends up to about day 10, and you may see signs of redness or discoloration, swelling, heat and pain. But when we have infection, then you have clinical signs and symptoms of infection. And you should really be basing your diagnosis of infection on those clinical signs and symptoms, which are increasing redness or discoloration, increasing pain, increased swelling, increased heat, possibly spreading cellulitis, and there may be presence of pus. So for a reminder of how to assess for wound infection in clinical practice, then I would say to look at the International Wound Infection Institute document from 2022. The third principle of wound bed preparation is moisture, and this is essential to promote wound healing and to protect the peri-wound skin from maceration. So moisture balance is particularly important, should I say. So exudate is produced as part of the normal wound healing response to tissue damage, often in copious amounts initially, but that should reduce as the wound heals. So the key thing is to manage the exudate. You need to observe the amount and viscosity of the exudate when selecting a wound dressing, and this will aid the decision for how often the dressing should be changed. And the final principle of wound bed preparation is E for edge. So advancing or non-advancing edge. So you need to look at the edge of the wound to assess for epithelial advancement. So if we look at this gentleman, which I showed you here, you can see how the skin tear is healing. And what we can see is presence of a healthy wound bed. And we can also see the leading margin of the epithelial tissue that's migrating across the wound bed to heal that skin tear. Of course, what you also need to consider is the edge of the wound in terms of whether there's a rolled edge, epibole or callus, which would need treatment. So what are my key messages with regards to skin tear assessment? Well, I would argue that healthcare professionals need to have a clear understanding of the definition of a skin tear and differential diagnosis to assess correctly. The ISTAP toolkit, including the skin tear decision algorithm, should be used to support accurate assessment. Assessment of a skin tear requires a set of first aid measures, including controlling the bleeding, cleansing the wound, and reapproximating the skin tear flap. The ISTAP classification system should then be used as it's been validated, and that should be used to categorise skin tears. And finally, the principles of wound bed preparation, whether that be time, DIME, timers or time CDST, should be used as a framework for wound assessment and documentation. So my final message is to help us spread the message that it's not just a skin tear. So for further information on assessment of skin tears, please see our new best practice recommendations developed with the WCN and NSWOC published last month. You have the QR code there that you can scan to access those, and they're free of charge. So thank you for listening, and I look forward to questions shortly.
Thank you all very much for those sessions. Absolutely fascinating. And it's really told a nice story from Norma Gill's birthday all the way through from ISTAT's beginnings, WCET's beginnings, until where we are today with lots of new information as well. We've also had a range of different questions. So can I invite the panelists to come back on the screen, please? Because there are quite a lot of questions here, and I know that we haven't got much time, but I think it's important that we actually try and answer some of these. So Sam, Denise, thank you very much, and thank you both for being here. Samantha, I'm going to ask you because this question comes up a lot, and I know you love answering it. So do Steri-Strips play a role in skin tear management?
I'll be short, no. An adamant no. And I think we have to change practice, because I know that wound closure strips are being used. I'm just being careful of using trade names here. What we know is where wound closure strips have been used, they are adhesive. That's what they're called. They're adhesive strips. So they can cause trauma on removal. So we would much rather they are not used, but I know they're the first port of call in most emergency departments. So this is a call out today, call to action for everybody to try and discuss with colleagues why wound closure strips should not be used. However, if they have been used, then we would advise using a sterile medical adhesive remover to remove them, because of course they can cause MARSI, medical adhesive related skin stripping on removal. So yeah, my initial answer was no, please don't use them.
Lovely. Thank you, Sam. Denise, have you got anything to add to Sam's comments?
No, I think that's the general. I think in some countries they might not have availability of other products. And so if anybody has that problem, they could probably ask us later. But I do generally think not for use.
Yeah. Yeah, we would definitely from ISTAP say don't use and reapproximate the flap, which Sam, you spoke about in your session. We've also had a question saying, and I think this is quite a common question and becomes confusing sometimes for staff. At what point would the skin flap be non-viable and require removal? Either Sam or Denise. Sam, looks like it's you.
I can come in first if you like. I think it's like anything you would do around skin assessment, looking at perfusion. I mean, we would always say if the skin tear has happened, fairly recently, as in the last few hours, do try and reapproximate and perhaps, wait 48 hours or so to reassess, because I think by then you kind of know whether the skin flap's going to take. And what you might find is that some of the skin tear flap takes and maybe some of the edges don't. So it's a question of, assessing regularly and documenting that. So, there's just been a few questions around documentation of other things this morning, but I think, documentation of skin and wounds is really important. So, if the skin tear flap is days old and the flap looks like it's a scab and crusty, I mean, yes, it's probably better to debride. But again, refer to my comments on debridement and being very careful. Building on what Kim LeBlanc also talked about with skin frailty and vulnerable skin, we have to be so careful in the handling of it. But yeah, certainly, wait around that 48 hours and then see if debridement may be needed or if it looks like it's going to take.
Thanks, Sam. And I also think that's really important because we're raising skin tears up as being a priority, being an acute wound, and that it is a wound, it's not just a skin tear. But once we start analysing this in more detail, then we do come to debridement. How do we reapproximate the flap? It's actually quite complex. It's not just stick it over and put a dressing on it, basically. So these are really good questions. Thanks, Sam. Denise, there's been a lot of questions about using scale at end of life. And in the UK, we don't particularly recognise that as an assessment tool. But what we do say is that it's good for description. It's also good to be able to use. What's your ideas on scale? Because you've done lots of different work globally.
I'll be honest with you, in the countries that I've been associated with, we don't use it either. And I think this is one of the problems. If something is not routinely used and researched and validated internationally, people get very confused about what is the best to use. I think in the countries that you work in the absence of something specific for your patient, you should use what is available to you, because everybody needs a good assessment and a documentation so that people can follow the plan. Particularly in end of life, because patients are so vulnerable and at risk.
Anthony, Sam, anything from you to add?
Yeah, well, I was just about to add really that in North America, Diane Krasner and colleagues are looking at trying to push for a new ICD coding that will, incorporate scale. So I'd say watch this space in the next few months. There are conversations happening about it, and people may see some new information coming out later in the year about scale and ICD coding. But I think depending on where you work, depending on how reimbursement works in your countries, I think we just have to be careful. And I agree, Karen, I think in the absence of a policy that says to use scale, then skin assessment is important, and using descriptive factors to say what a person's skin looks like in the different stages, particularly in the stages of dying, may be really important. But I think from the number of questions we've had and the chat, maybe it's worth doing something separate at another time on this topic area.
I think so. And I just think people may not recommend scale, some people may recommend scale, but I think Sam and Denise, you've both said it. It's about a good assessment of the skin at end of life and documenting it and ensuring that you highlight any areas that are at risk and manage it in an early preventative stage to make the patient comfortable. Now, there's lots and lots of questions about wound closure strips, silicone dressings, reapproximation, etc. And because we're actually running out of time massively, can I ask people to look at the best practice document that we've just had published, that Sam did put the QR code up there? And then that goes through which dresses we recommend, not to use wound closure strips, how to reapproximate the flap as well. So just remember, what you're doing when you're managing your skin tear is you want to protect that fragile skin as well. So you don't want to be putting anything onto the skin that's abrasive. Also think about when you remove the dressings as well, that you remove them in the direction of the skin tear, and you also use skin removers if required, because you don't want to add further damage. But the best practice document should be able to give you all those different hints and tips whilst thinking about antimicrobial stewardship as well. So you don't want to be causing more issues with antimicrobial resistance as well. And people have asked as well about best practice for skin tear in home versus inpatient settings. Best practice is best practice across all different care settings. So there shouldn't be any difference. It should be equitable across the different care. Also, Denise came up with a really good point there. Sometimes in resource limited countries, it's difficult to get hold of a lot of different products. But just bear in mind, you don't want to damage the skin, so use something that's non-abrasive. And once again, don't use the wound closure strips. Reapproximate those flaps, but don't be using anything to reapproximate with that would damage the skin, such as tweezers. You can use glue if necessary, but again, look at your local guidelines, and that's really important. We've had a few questions come in, and some really interesting ones actually. So Sam, I know you've answered this, but I'm not sure that people can see it. Jane was asked about the effect of menopause as a cause of skin tears, and should we be looking at that as well when we're looking at skin at risk?
Yeah, I mean, absolutely. I think, it's something perhaps we haven't necessarily mentioned in our recommendations. But as I mentioned in my response to the question, there's no direct evidence that the menopause is a cause of skin tears. I'm sorry, I put skin type there, cause of skin tears, but it's probably a contributing factor because of the changes in estrogen levels, which we know increases skin fragility. So my own opinion is that it's the physiological effects of menopause which increases the susceptibility even to damage. But yeah, I don't know, Kim, is there anything, I don't know, that you've seen around menopause and what we should be thinking about?
There's nothing specific in the literature that I've ever seen that's out there on it, but we do, when you think of menopause as being part of the natural part of aging. And what we have seen is that skin changes associated with aging are what put you at higher risk for developing a skin tear. So certainly those physiological changes, of which menopause is part of that, would put someone at higher risk. But it's not in isolation. We have to look at that whole bundled approach where we look at other environmental factors such as smoking history, other medications we may be taking, exposure to sun, etc., and your skin type. They're all going to work in combination. So I think that, it is something that when we're talking about women's health and we're looking at the aging process, we have to look at, certainly aging skin within that.
Yeah. Karen, can I come back in on that?
Of course you can.
Oh, I don't know if Karen's, sorry, I was going to come back in. I didn't know if you'd frozen, Karen.
No.
Yeah, I think the point somebody was, sorry, I think it was Jane McSwindle was making was that maybe it's not age, like older age, menopause can start at an earlier age. So I guess there's the age aspect, but it's also perhaps when the menopause starts. But yeah, I think it's something that ISTAP, in conjunction with WCET, could perhaps explore in a little bit more detail. And if there's anyone listening in that has any evidence on this, please do send it.
One of the evidences is there, though, Sam, is that it's not age itself that causes skin tears that put you at higher risk. It's the skin changes associated with aging and frailty that develops as we age that puts you at higher risk. So that if you look at that, then the whole idea of, well, if you start menopause at 40, then your skin changes have already started. So that actually supports that argument that it's not age itself, but it's a skin changes associated with aging. And if your natural aging process starts earlier because you went into menopause earlier, one could make the argument that that supports that.
Thank you, ladies. There's loads to think about, isn't there, when you really dig into it? And like you were saying, Sam, this is not just a skin tear. It's quite complex damage to the skin. There's just something I just want to answer. Bridget, you asked if you could make in-house training. Can I use the best practice? Of course you can. We recommend that you use it. So feel free to use best practice documents. And ladies, I've got a really interesting one here from Shelley, who says, with the increase in cosmetic surgery, do you think this is something that's going to affect the future aging skin integrity?
Ooh, can I answer that one?
Of course you can. Yeah.
So one of the things we know is that there is no magic potion. There is nothing that we can really do that's going to necessarily change the composition of our skin. So with plastic surgery, there is the removal of loose skin, etc. But where does plastic surgery normally occur? It normally occurs on the face, on the chest area. One thing that, to my knowledge, we haven't come up yet with is something for the hands, arms, and legs in terms of, tightening the skin. So yes, there's different collagens and different that will have short-term tightening of the skin. But as of yet, there's nothing magic that's actually going to come out and going to help the skin. So while we can tighten up our faces and but do we get a lot of skin tears on your face? No. And, I always say that, you see these women with these, particularly women who have these beautiful faces and they're in their 70s and they look about 50, but look at their hands. And where the number one area for skin tears are on the hands, forearms, and shins. So I do think that it's so important that that we remember, just because your face looks young and you've had plastic surgeries, keep going preventing skin tears elsewhere.
Oh, thank you, Kim. Marianne's asked if it's impossible to remove dirt such as gravel from the skin tear flap, would it be acceptable to cut some skin off? I shall open that to anybody that would like to answer that.
lot of it depends on your scope of practice, where you work, what is your scope of practice. In some cases, I mean, that's a form of debridement. So you have to look at where is your setting. If you're an emergency department, perhaps it would be appropriate, and you've also have a team around you to control bleeding, pain, etc. If you're in the community or long-term care, you have to weigh at how much is this going to bleed, how much additional trauma are you going to do you have the right equipment and the right environment to actually do that? And do you have the knowledge, skill, and judgment? Do you have the appropriate skill set to be able to do that?
Thank you, Kim.
Maybe just to add to that, Karen, yeah, I mean, we know that, and I think I mentioned your skin tears are at risk of contamination. So you do have to think about tetanus status. And I would say, if it's not in your scope of practice, then refer on for, an urgent referral if there is that risk. Sometimes wound cleansing will get rid of some of that debris, but not always. So yeah, I'd support what Kim is saying, and it's around scope of practice.
Thank you, Sam. Kim. Jenny, I think this one might be for you. Mary's asked, can an increase in itching be considered a risk factor to develop a skin tear? And is there a recommendation on how much moisturizer needs to be applied to the limb?
Thank you. I'm not aware of any specific amount of moisturizer that needs to be applied to the skin. I think there are other factors to be considered there in terms of the amount. That is the length of the limb, if the person is male versus female. But generally, some people refer to per limb size. It's a bit like the slip, slop, slap, and how much sunscreen do you apply? So, anywhere from a very generous daub about the size of a 50-cent piece, some people say upwards of a teaspoon per limb. But I think it also depends on the viscosity of the moisturizer that is being used, or the thickness. But it's important then that the moisturizer is actually smoothed on in a downward motion, not a rubbing motion, so that you don't cause any folliculitis by disturbing the base of the hair follicle, and to make sure that the moisturizer is actually smoothed into the skin so that it is no longer visible. And then you'd basically have to look very carefully at the skin for any areas that have been avoided. So it's a little bit of trial and error. I think, as I said, depending on the characteristics of the individual, the size of their arm or their lower leg, and the type of moisturizer that is being used. And as Kimberly said earlier on, Professor Carolyn Carville's research clearly identified that twice daily moisturizing is the important factor in reducing the incidence and the severity of the skin tears. And also, we don't often, I think, talk enough about oral hydration and the importance of fluid replacement as prevention of skin tears. So reducing that dryness of the skin that occurs from the aging process and loss of water from the skin.
Thank you, Jenny. Angela, have you got anything to add to Jenny's answers?
Hi, everybody. I think it's really a challenge for us to deal with the skin tears, and we have to have a lot of attention to all of these points that Jenny told us, because many times we can do some mistakes. So we can have attention, and we need to be developing and knowing what are being published and participated this kind of things to have how to deal with these situations.
Oh, thank you, Angela. There's just a few more questions that are quite general, and I realise that we're just running out of time. For dressing selection, if you have a look at the best practice document, it'll talk about how you need to assess, first of all, obviously categorise your skin tear and then decide which dressing you need. But you need a dressing that's not going to cause further trauma to the skin on application and removal. So think about also using an application to help get rid of the glue on any sort of dressing so you don't rip the skin. For twice daily moisturising, yes, we would like you to do twice daily moisturising to keep the skin supple. Sometimes you can only do it once a day, so once is better than no times at all. Kimberly, can I just hand back to you for a minute, please?
Yes. So, thank you, Karen. I would just be remiss. I realized when I was doing my history of ISTAP that I kind of stopped at 2016. And so I was wanted to add to the history of ISTAP that we wouldn't be where we are today without the assistance of Nurses Specialized in Wound Ostomy Incontinence Canada. In 2016, we held a strategic planning meeting, and I very purposely invited Catherine Harley, the CEO from NSWAC, to come to help us with our strategic plan. And from there, the part of the method of my madness was that we convinced her to stay on as our CEO, and we became a sister society of Nurses Specialized in Wound Ostomy Incontinence Canada. And really, without that really helped us grow internationally and allowed us the space to get to where we are today. So, realizing that when I was providing you the brief history, trying to jam it all into just a few minutes, I kind of stopped at 2016. And so I just wanted to let everybody know that really it was under the guidance of Kathy Harley and Troy Curtis and the rest of the NSWAC team that we were really able to continue to shape and grow ISTAP to where it is today.
Thank you, Kim. That's brilliant. And I'd just like to say to Liz, Liz, I think that's a great idea. We can do another session just based on questions. We can just all have a lovely chat for maybe an hour, because I can talk a lot and the rest of us enjoy talking as well. Just before I hand over to Denise for the closing remarks, can I just remind you this is all recorded, so you'll be able to access it on the ISTAP or the WCET websites within the next week. You will all receive your certificates within 24 hours. If you're not already a member of ISTAP, please do join us. If you're not a member of WCET, please join them as well. Remember, we're all here to help you, and we have lots of free resources on the website, so please do make good use of them. So thank you all very much for listening, and without further ado, I'd like to hand over to Denise for the closing remarks.
Thank you to everybody, to all speakers, and to celebrate with us the Norma and Gill Day. Thank you.
Thanks, Angela.
Thank you for joining us today for Norma N. Gill's birthday celebrations on the theme of skin health and skin tears doing the right thing. I hope you enjoyed this collaborative webinar between ISTAP and WCET as much as we did. And I'd first of all like to thank our speakers who volunteered their time and knowledge freely. Dr. Kimberly LeBlanc, who talked about skin injury prevention, Dr. Jenny Prentice, who enlightened us on the science underpinning skin tears, and Samantha Holloway, who discussed assessment and treatment of skin tears. I would like to remind you at this point that we will be sending out a survey, and it's very important that you complete this and resend to us so that we can improve for future endeavours. I think there were many important take-home messages, and thank you so much for joining in the question and answer session. For me, the importance of performing a risk assessment of all ages was highlighted, promoting skin integrity, especially in those at risk, Identifying modifiable risk factors utilising holistic assessment and an individualised plan of care. The importance of educating patients and carers, empowering them with the knowledge to assess themselves and for self-care. We were reminded of the updated 2025 definition, which now includes the mechanism of injury. And we were reminded of the many resources that are freely available on the ISTAP website, including the Skin Tear Toolkit and the ISTAP classification tool, which is now translated into 14 languages and validated also. I would now like to thank Dr. Karanouzi, President of ISTAP, Laurent Chabal, President of WCET, the Education Chairs Mary Hill from ISTAP and Angela Baccara from WCET, and Troy Curtis, who did a wonderful job bringing this all together, and he represents ISTAP work streams and for collaborations and partnerships, and also Baccara Millane, our management company, and especially Susan Barber. I'd like to take this opportunity again to remind you to please register for the WCET and NSPOC Joint Congress, which will be in April from the 24th to the 28th, 2026 in Vancouver, Canada. You can now submit your abstracts. It is now open for submission, and I would also like to remind you to save the dates. This is a really important event and we're very excited about it. I'd also like to remind you of the value of being a WCET and an ISTAP member. The WCET membership is a mere 25 Great British Pounds or the equivalent of $35 a year, and we have lots of tools and educational opportunities available on the website, journal, newsletter, which you know is the bulletin. You can go to our website to join, and if you have problems you can contact our admin via email. The ISTAP membership is free, and again there's lots of tools and free educational opportunities online, and you can also join online at the ISTAP website. So thank you again for joining us. We hope you enjoyed it, and we would like to remember Norma N. Gill on her birthday.